Welcome back to the deep dive. Today, we are doing something a little different, something very specific, and I'd say high stakes.
Definitely high stakes.
We're basically putting on the white coats and taking on the role of your virtual study partners.
Or maybe your virtual mentors.
Exactly. For one of the most grueling rites of passage in the medical world, the MD anesthesiology exams.
And we're getting specific. We're looking at the Gujarat University curriculum standards, but really, this stuff is universal.
Oh, absolutely. The physiology we're talking about today, it applies to the DNB, the FRCA, any major anesthesia board exam across the globe.
That's right. And we aren't just skimming the surface today. We're going deep into one of the most, well, dreaded, yet highest yield topics in the entire syllabus.
Valvular heart diseases and prosthetic valves.
This is the topic that really separates the novices from the experts.
Oh, the valves. I feel like everyone has a love-hate relationship with this topic. It's mechanically fascinating.
That's plumbing, really.
It's just plumbing, but the physiology can get so complex so fast, and the pressure in an exam setting.
It is intense.
Yeah.
But think about it. This is the cornerstone of the entire cardiovascular curriculum.
You can't avoid it.
You just can't. If you are sitting for your MD exams, whether it's the theory papers where you have to write a 20-mark answer or that long case in the practical Viva,
You're going to get one.
you are almost guaranteed to face a patient with mitral stenosis or aortic stenosis. It is unavoidable.
So the mission today is to act as that senior faculty member who, sits you down the night before the exam and says, okay, here's what you actually need to know to pass.
Exactly.
We've pulled from a massive stack of sources for this one. I mean, Miller's Anesthesia, obviously that's the Bible of the field.
Can't do without Miller.
But we've also dug into long and short cases in anesthesiology, which is so crucial for the exam format.
It really is. And the objective anesthesia review from the Tata Memorial team, plus Yao and Artusio's for that problem-based approach.
We are going to synthesize all of it.
And we need to move beyond just memorizing drug doses. We have to understand the hemodynamic logic.
The why.
The why. Because in a Viva, the examiner doesn't just want to know what you do. They want to know why you are doing it. They are looking for the traps.
And we are going to help you avoid those traps. So let's dive right in. Section 1, Introduction to Valvular Heart Disease, or VHD. How do we define this in a way that satisfies an examiner?
Simply put, VHD is any structural abnormality of the cardiac valves that alters the unidirectional flow of blood.
Or messes with the pressure gradients.
Or disrupts the pressure gradients between chambers. But for the anesthesiologist, the definition is functional.
Right.
It is a failure of the pump mechanics. The heart is a pump, and the valves are the check valves. When they fail, efficiency just plummets.
Okay. And we need to understand the burden of disease. I know this is changing.
It's shifting, and this is a key point for your introduction. You have to mention that.
Why, I saw that in Miller. It talks about this big shift from rheumatic disease to more degenerative disease.
In the West, yes, absolutely. In the U.S. or Europe, you are seeing calcific aortic stenosis in the elderly. It's wear and tear.
But that's not the whole story.
Not for your exams, especially in the Indian context. This is critical. Rheumatic heart disease is still the king.
Long and short cases really hammers this home, doesn't it?
It emphasizes it heavily. If you get a 30-year-old female patient in your practical exam with a diastolic murmur, your first, second, and third differential is rheumatic mitral stenosis.
So don't jump to degenerative calcification if the patient is young and from a developing region. That's a classic rookie mistake.
It's a huge mistake.
Yeah.
And the management spectrum, that's changed too. It used to be, well, medical management or open surgery.
Or nothing.
Pretty much.
Yeah.
Now we have this huge middle ground of interventional cardiology. We're talking balloon valvotomies, TVIs.
Which means we're seeing these patients for other things.
Exactly. As anesthesiologists, we're seeing these patients not just for valve replacements, but for non-cardiac surgeries.
Gallbladders, fractures.
C-sections. You have to know how to manage a bad valve when you're not fixing the valve.
That is the key, isn't it? You're managing the physiology while the surgeon is busy fixing a hernia.
That's the whole game.
Okay, so let's get into that physiology. Section 2, Normal valve function and cardiac hemodynamics. We have to understand the normal to be able to fix the abnormal.
Correct. The valves are basically the traffic lights of the heart.
Good analogy.
They ensure unidirectional flow. When they fail, you get one of two fundamental problems: stenosis or regurgitation. And you must understand the difference in how the heart adapts. This is the pressure versus volume divide.
Okay, let's unpack that. Pressure overload versus volume overload.
Stenosis doesn't matter if it's aortic or mitral. causes a pressure overload. The chamber behind the stenotic valve has to push harder and harder to get blood through a narrow door.
So the muscle adapts.
The heart responds with concentric hypertrophy. The walls get thick. Imagine a weightlifter.
Like building bulk.
Exactly.
Hmm.
But a bulky muscle in the heart is a stiff muscle. Compliance goes down.
And that's crucial for us.
It's everything for anesthesia. These hearts have small cavities and thick walls. They don't relax well, so they're incredibly dependent on the atrial kick just to get filled.
And then the other side of the coin is regurgitation.
Right. Regurgitation is a volume overload. Blood flows forward, but some of it leaks back.
So the chamber has to handle more total volume.
It has to accommodate more fluid,
Yeah.
the normal amount, plus the leak. So the heart responds with eccentric hypertrophy. The chamber dilates. It gets bigger, baggier.
So a dilated heart is more compliant.
Usually, yes. It can handle volume shifts a lot better than that stiff stenotic heart. And this distinction, pressure versus volume, it
Right.
dictates everything.
Everything.
Your fluid management, your choice of pressors, your induction speed, it all comes back to this.
We also need to touch on the concept of fixed versus dynamic cardiac output. That's a phrase examiners love.
Oh, they love it. Stenosis creates a fixed cardiac output state. You cannot increase the stroke volume because the door is jammed shut.
So you're limited.
You're completely limited. If the body needs more oxygen, like during intubation, stress, or pain, the heart cannot pump more blood per beat. The only thing it can do is increase the heart rate.
Which has its own problem.
Big problems. But with regurgitation, the state is more dynamic.
Yeah.
You can actually manipulate the systemic vascular resistance, the SVR, to help the heart improve its forward flow.
That's a great setup. Okay, let's get specific. Section 3, mitral stenosis, or MS. This is probably the most common long case in the MD exams.
Without a doubt. Mitral stenosis is the classic rheumatic lesion. It's almost always a sequela of rheumatic fever.
So what happens to the valve itself?
The mitral valve leaflets fuse, the commissures get stuck together, and you get that classic fish mouth or buttonhole appearance on echo.
Okay, what's the hemodynamic domino effect here? Walk us through that.
It's a chain reaction of backward failure. The obstruction is at the mitral valve, so the left ventricle, the LV, is actually underfilled.
It's protected, in a way.
It's protected. It's usually normal-sized or even a bit small.
Yep.
But the left atrium, the LA, is suffering.
That's where the pressure builds up.
Pressure builds up in the LA because it can't empty. That pressure then reflects back into the pulmonary veins, leading to pulmonary venous hypertension.
And it doesn't stop there.
No. Eventually, that hits the pulmonary arteries, causing pulmonary arterial hypertension, PAH, and finally, it just wrecks the right ventricle. The RV fails.
So when you're evaluating an MS patient for surgery, you're really evaluating their lungs and their right heart more than the LV.
Precisely. You look for dyspnea, hemoptysis, and signs of right heart failure, like jugular venous distension.
And there's a specific syndrome to watch for.
Yes, here is a nugget from Objective Anesthesia Review. Watch out for Lutembacher syndrome.
I saw that. What is the specific definition there? I feel like this is a classic exam question.
It's a total Viva favorite. Lutembacher syndrome is the combination of mitral stenosis and an atrial septal defect, an ASD.
Okay, so why is that tricky?
It's tricky because the ASD acts as a pop-off valve. It decompresses the high left atrial pressure into the right atrium.
So the lungs might seem okay.
The patient might not have as much pulmonary congestion. Their lungs might sound surprisingly clear, but they will have massive right heart overload and failure much, much earlier. It completely changes the clinical picture.
Note taken. Lutembacher's. Now, what about complications? Atrial fibrillation seems to be the big one with MS.
It's ubiquitous. The left atrium dilates so much that it disrupts the electrical pathways. You get AF.
And AF leads to stasis.
AF causes stasis,
Yeah.
and stasis causes thrombus, usually in the left atrial appendage. That's why these patients are almost always on anticoagulation.
Okay, let's move to section 4. Treatment modalities for MS. We aren't surgeons, but you're right. We need to know the options to pass the exam.
We always start with medical management. Rate control is number one.
Beta blockers, calcium channel blockers.
Exactly. You want to extend diastole to give that blood as much time as possible to squeeze through that narrow valve, and anticoagulation, of course, for the AF.
But the sources, they really highlight the interventional treatments heavily.
Yes. For the exams, you absolutely must mention percutaneous balloon mitral valvotomy, or PBMV.
So how does that work?
You essentially stick a balloon across the valve, usually coming up from the femoral vein, and you inflate it to crack the valve open.
And who is the ideal candidate for that?
It's great for young patients with pliable valves that aren't heavily calcified. If you see a young woman on the exam with MS, PBMV is likely the first-line intervention you should be discussing.
What about closed mitral valvotomy, CMV?
It's more historical, but still done in some centers, especially in developing contexts where bypass isn't readily available.
And that's done blind.
Pretty much. It's done blind through a thoracotomy. But the gold standard for a wrecked calcified valve is mitral valve replacement, MVR, on full cardiopulmonary bypass.
Okay, here we go. This is the meat of it for our listeners. Section 5, anesthetic goals in mitral stenosis. If you remember nothing else from this deep dive, what is the mantra for MS?
The mantra for MS is slow, sinus tight.
Let's break that down. First, slow.
You must control the heart rate. This is Physiology 101. Filling of the coronary arteries and the ventricles happens during diastole.
And tachycardia just kills your diastolic time?
It shortens diastole disproportionately. In MS, the blood needs every millisecond it can get to cross that narrow valve. If you race the heart, you slash the filling time, the gradient across the valve spikes, and cardiac output just drops off a cliff.
So on a practical level, you're saying avoid ketamine.
Absolutely avoid ketamine. It causes tachycardia. Avoid atropine. Avoid pancuronium. You want the heart rate on the lower side of normal, say 60 to 70 beats per minute.
Okay, next part of the mantra, sinus.
Maintain sinus rhythm. We talked about the stiff ventricle, or in this case, the underfilled ventricle. In MS, the atrial kick, that final squeeze of the atria, contributes up to 30 or even 40% of ventricular filling.
So losing it is a disaster.
If they flip into AF, they lose that kick and they can go into hemodynamic collapse. If they're in AF pre-op, you control the rate. If they're in sinus, you fight tooth and nail to keep them there.
And the last part, tight.
This refers to afterload, or SVR. You want to maintain a normal to slightly high SVR.
Why is that?
If the blood vessels dilate too much, you get hypotension, and the body reflexively causes tachycardia to compensate, which we just said is terrible. Also, with a fixed output, you need that resistance to maintain perfusion pressure to the vital organs, especially the coronaries.
What about fluid? That seems like a tricky balance.
It's a total tightrope. You need enough preload to fill the left atrium, but if you give too much, you tip them right into pulmonary edema because the dam is blocked.
So careful, titrated fluids?
Very careful, and importantly, manage the pulmonary hypertension. Avoid hypoxia, hypercarbia, and acidosis. All of those trigger hypoxic pulmonary vasoconstriction, HPV, which will absolutely crush a failing right ventricle.
Slow, sinus, tight. Got it. Let's flip the script now. Section 6, mitral regurgitation.
NMR is a different beast entirely. Etiology can be rheumatic, but you also see it a lot with mitral valve prolapse, MVP, or ischemic papillary muscle dysfunction after an MI.
Infective endocarditis, too.
Yes, that can wreck the valve.
And the pathophysiology is volume overload.
Right. During systole, when the ventricle squeezes, blood should go out the aorta. In MR, the mitral valve doesn't seal properly. A chunk of that blood goes backward into the left atrium.
So the LV has to pump extra volume just to maintain forward flow.
It has to pump a massive stroke volume just to get a normal amount of blood to the body. It effectively becomes a double outlet ventricle. It's working overtime.
It is working overtime. And compliance is a big factor here, right? Acute versus chronic.
Huge factor. In chronic MR, the LA dilates slowly over years and years. It becomes big and baggy, so the pressure doesn't rise that much. Patients can tolerate this for a long time.
But acute MR is a different story.
Acute MR, say, a papillary muscle ruptures from an MIR. The LA is small and stiff. The pressure shoots up instantly, transmits straight back to the lungs, and you get flash pulmonary edema. Acute MR is a surgical emergency.
Okay, for treatment, Section 7, we have repair versus replacement. Miller seems to heavily favor repair.
Always. If you can, you repair. Mitral valve repair is preferred over replacement because it preserves the subvalvular apparatus.
The choroidal and papillary muscles.
Exactly. They help the left ventricle contract properly. They act like guy wires. If you cut them all out to put in a replacement, LV function often drops post-op.
And now there's the Mitral clip.
Right, a percutaneous clip that basically stitches the leaflets together. It's a great option for high-risk patients who wouldn't tolerate open-heart surgery.
Let's get to the anesthesia. Section 8. Anesthetic goals in mesorrhagia. What's the mantra for this one?
Fast, full forward.
The complete opposite of MS. Okay, let's break it down. Fast.
Well, mild tachycardia. We're not talking about racing the heart, but a rate of 80-100 beats per minute is often desirable.
And the logic there.
Regurgitation happens during systole. If the heart rate is faster, the duration of systole per minute is actually less relative to diastole.
Less time for the leak to happen.
Less time to leak backwards. Plus, A slightly smaller ventricle from a faster rate helps the leaflets coapt, or approximate, a bit better. Bradycardia is your enemy here. It distends the ventricle and pulls the leaflets apart, which makes the leak worse.
Okay, forward.
You want to encourage forward flow out the aorta, and the way to do that is to lower the resistance in the aorta.
Afterload reduction.
Afterload reduction.
Yeah.
Vasodilators are your friends here. If the SVR is high, it's harder to push blood out the aorta, so more of it goes the easy way, back into the atrium.
And full.
Maintain preload. Even though the heart is already dilated and volume overloaded, you need that volume to ensure you have enough forward stroke volume. Don't run them dry.
So for Medi-Car, practically, you want to avoid a drug like phenylephrine if you can, because it just cranks up the afterload.
Ideally, yes.
Yeah.
If you need a pressor, ephedrine might be a better choice.
Okay, so the beta activity?
Right. It has some beta activity to keep the rate up and the contractility strong, unlike phenylephrine, which is a pure alpha agonist and can cause a reflex bradycardia.
Okay, moving down the flow of blood. Section 9, aortic stenosis, AS. This is the one that scares everyone.
And it should. AS is the highest risk valvular lesion for non-cardiac surgery. Goldman's risk index flags this as a major, major killer.
Why is it so dangerous? What's the core problem?
It creates a severe fixed cardiac output. The LV outflow tract is blocked. The LV responds with massive concentric hypertrophy.
So it becomes incredibly thick.
Incredibly thick and incredibly hungry for oxygen. But, and here's the catch, the deadly part, because the pressure inside the ventricle is so high during systole, it crushes the blood vessels in the subendocardium.
The coronaries.
The very coronaries that are supposed to feed that thick muscle. So you have a heart that needs more oxygen but gets less blood flow. It is a perfect setup for ischemia.
And the etiology for AS.
Usually calcific or senile in older people. In younger patients, you think of a congenital bicuspid aortic valve. Rheumatic is possible, but it usually comes along with mitral disease.
Section 10, treatment. Medical management isn't really a thing here, is it? It feels like a plumbing problem.
It is a mechanical problem. You have to fix it. Medical management is just to bide time.
So surgery.
Surgical aortic valve replacement, SAVR, was the gold standard for decades. But now, TAVI by transcatheter aortic valve implantation has just exploded.
I know Miller talks about this extensively.
It's a revolution. We are putting new valves in through the femoral artery in 80-year-olds, sometimes just under sedation.
So for the exam, what are the specific complications of TAVI that we need to know as anesthesiologists?
Okay, so the anesthesia is unique. To deploy the valve, they often rapid pace the heart to 180 or 200 beats per minute.
To create temporary cardiac standstill.
Exactly. It basically stops the flow so the valve doesn't get ejected. But that rapid pacing can cause profound ischemia.
What else can go wrong?
You can have an annular rupture. You can obstruct a coronary oscium if the native leaflet is pushed over it. Or you can damage the conduction system and they end up needing a permanent pacemaker.
Right. Okay. Section 11. Anesthetic goals in AS. This is absolutely critical.
The mantra is normal rate, sinus rhythm, high afterload.
Let's start with normal rate.
You cannot tolerate tachycardia because that thick, hungry heart needs diastole to get its oxygen supply.
But you also can't have them go slow.
You also cannot tolerate bradycardia. Since stroke volume is fixed, cardiac output equals stroke volume times heart rate. If the rate drops, the output drops linearly, you have no way to compensate.
So there's a sweet spot.
A very narrow sweet spot, around 60 to 80 beats per minute.
Sinus rhythm?
Absolutely crucial.
Yeah.
That stiff LV needs the atrial kick for filling. Loss of sinus rhythm can cause immediate and catastrophic hemodynamic collapse.
So if they flip into AF mid-case...
You cardiovert aggressively.
And high afterload. This is the one that's counterintuitive for some people. Why do we want high resistance?
Because the coronary arteries fill during diastole. And the driving pressure for that is the aortic diastolic pressure.
So blood pressure is everything.
If the systemic blood pressure drops, if you get hypotension, the driving pressure for the coronaries vanishes. The heart becomes ischemic, it pumps less, the pressure drops further.
Yeah.
It's the spiral of death.
So you have to maintain diastolic blood pressure.
You must. Use phenylephrine. Treat hypotension immediately and aggressively.
So unlike MR, where we want to vasodilate, in AS, vasodilation can be fatal.
Exactly. Spinal anesthesia was historically considered an absolute contraindication in severe AS for this exact reason. The sympathectomy just drops the SCR too fast.
We'll come back to the spinal controversy. Let's quickly touch on aortic regurgitation, AR, in section 12 and 13.
AR is another volume overload lesion, but this time of the LV. Blood leaks back from the aorta during diastole.
Etiology.
Can be from aortic root dilation, think syphilis, Marfan syndrome, aneurysms, or from endocarditis damaging the valve leaflets. The unique physiologic sign here is that wide pulse pressure, very low diastolic pressure.
Which again puts coronary perfusion at risk.
Correct. The anesthetic goals, which is section 14, are actually quite similar to Mr. Fast and 4.
Okay, so fast to shorten diastole, which means less time for the blood to leak back.
Right.
And forward, meaning reduce afterload, to make it easier for blood to go out to the body instead of leaking back.
That's the goal. But you have to be careful not to drop the diastolic pressure so low that you compromise the coronaries. It's a delicate balance.
And avoid bradycardia.
Avoid bradycardia at all costs. A slow heart rate increases the regurgitant volume per beat and massively distends the LV.
Okay, section 15, the comparison cheat sheet. If you're in the exam, your mind goes blank. How do you visualize this?
Think in pairs. Stenotic lesions, AS and MS, generally need slower rates and demand sinus rhythm.
Pressure problems.
The pressure problems. Regurgitant lesions, AR and MR, tolerate faster rates and benefit from vasodilation.
Volume problems.
They're volume problems.
Yeah.
Stenosis is pressure work. Regurgitation is volume work. If you can keep that straight, you're halfway there.
And what about drawing the pressure-volume loops? That seems like a high-yield skill for a Viva.
You must practice this. For AS, the loop is tall and narrow. High pressure, so it's tall, but low stroke volume, so it's narrow.
And for Miss MR?
For MR, the loop is short and wide. Low pressure, so it's short, but a massive volume swing, so it's wide. If you can draw these on the blackboard during your Viva, you've basically passed that question.
Let's move to the practical management. Section 16, preoperative assessment. What are we looking for?
Functional capacity is king. Can they climb a flight of stairs? That's 4 METs. If they can't do that without getting symptoms, they are high risk.
And we look for specific symptoms.
For AS, you look for the SAE triad, syncope, angina, dyspnea. If they have those symptoms, their survival curve just drops off a cliff.
And investigations, echo is key.
Echo is the gold standard. You need the numbers. For AS, a valve area less than 1.0 centimeters squared is severe. A mean gradient over 40 millimeters of mercury is severe.
And for MS?
For MS, a valve area less than 1.5 is significant, and less than 1.0 is very severe.
Section 17, intraoperative management. Let's talk induction.
For severe AS or MS, you need a cardiostable induction. Etomidate is often preferred because it maintains SVR and contractility really well.
Propofol is risky.
Propofol is very risky in severe AS because it's a potent vasodilator and can drop your SVR precipitously. If you have to use propofol, use it slowly in small increments and have phenylatrine drawn up and ready to go.
And for the regurgitant lesions, MR and AR.
You have a lot more leeway. A balanced anesthetic technique is fine. Ketamine can actually be a good choice in MER because it bumps the heart rate slightly, which fits our fast goal.
Monitoring. What's the standard of care?
In severe VHD, put the arterial line in before you induce. You absolutely want to see the beat-to-beat blood pressure during that critical period.
And central axis?
For complex cases, a CDP is standard, though its correlation to actual volume is, heavily debated. For a valve repair, a TE transesophageal echo is essential. You have to check the surgical result immediately.
Moving on to section 18, post-op care.
The big thing to watch for is fluid overload. These patients have high extravascular lung water. Diuresis is often needed to get them off the ventilator.
Pain control is vital.
Vital to prevent tachycardia and hypertension. And watch for atrial fibrillation. It's the most common post-op complication after cardiac surgery.
Okay, let's shift gears to the hardware. Section 19, prosthetic heart valves.
2 main categories you have to know: mechanical and bioprosthetic, which are also called tissue valves.
Let's start with mechanical valves.
These are made of pyrolytic carbon. They're incredibly durable. They will last a lifetime.
But the downside?
They are thrombogenic. The patient needs lifelong anticoagulation with warfarin, and you'll hear that distinct, sharp click on auscultation.
Then you have bioprosthetic valves.
Right. These are made from porcine, which is pig or bovine, cow, pericardium. They are much less thrombogenic, so usually no long-term warfarin is needed, maybe just aspirin.
But they don't last forever.
That's the trade-off. They wear out in 10 to 15 years, so we tend to use them in older patients who can't tolerate blood thinners or in women of childbearing age who want to get pregnant.
Why specifically in pregnancy?
Warfarin is teratogenic. It causes serious birth defects. So a young woman might choose a tissue valve, have her children, and accept that you'll need to redo surgery later in life.
Section 20, complications of these valves.
Thromboembolism is the big, scary risk with mechanical valves. If the valve clots, it can get stuck shut or stuck open. That is a catastrophe.
And with the anticoagulation comes bleeding.
Of course, bleeding is the other side of that coin. And infective endocarditis prosthetic valves are magnets for bacteria. Any infection in the bloodstream can seed the valve.
Okay, this is a guaranteed exam question. Section 21, anticoagulation bridging. The scenario is, doctor, you have a patient with a mechanical mitral valve coming for a cholecystectomy. How do you manage the warfarin?
Okay, here is the examiner-approved protocol. You have to know this cold.
Lay it out for us.
Step 1,
Yeah.
stop warfarin 3 to 5 days before surgery. Step 2, as the INR drops, usually below 2.0, you start bridging therapy with therapeutic doses of heparin,
LMWH or unfractionated.
either low molecular weight or unfractionated. Then step 3, stop the heparin shortly before surgery. That's 4 to 6 hours for an IV unfractionated drip or 24 hours for therapeutic LMWH.
And you check the INR in the day.
Check the INR the morning of surgery. It should be less than 1.5. Finally, you restart heparin post-op once the bleeding risk is controlled, and then you restart the warfarin.
Why do we have to bridge? Why not just stop the warfarin?
Because the risk of stroke with a mechanical mitral valve off anticoagulation is very, very high.
But it's different for an aortic valve.
Aortic mechanical valves have a lower thrombotic risk, so sometimes you don't need to bridge if they have no other risk factors. But for the exam, playing it safe and describing the bridging protocol, especially for mitral valves, is usually the right answer.
Okay, section 22, the anesthetic management for one of these patients having non-cardiac surgery.
First thing, antibiotic prophylaxis is mandatory. No exceptions. You have to prevent endocarditis.
And intraoperatively.
Intraoperatively, if the valve is functioning well, you manage them based on their underlying ventricular function. If the valve is dysfunctional, if it's stenosed from pannus formation or it's leaking, you manage them exactly like the native lesion we discussed earlier.
Right. Okay, section 23, regional anesthesia in VHD and prosthetic valves. The big controversy. Can you give a spinal to a patient with severe AS?
Historically, the answer was absolutely not. It was listed as a contraindication.
Because of the SVR drop.
Fear is the sympathectomy causes massive vasodilation, dropping the SVR and killing the coronary perfusion. That spiral of death.
But practice has changed.
Modern practice is more nuanced. You can do a graduated neuraxial block like a very carefully titrated epidural or a low-dose continuous spinal catheter. But a single-shot, high-dose spinal is still incredibly dangerous and probably a fail in the Viva if you suggest it without major caveats.
And for patients with prosthetic valves, what's the issue there?
The issue there is the anticoagulation. You cannot stick a needle in their back if they are fully anticoagulated.
The risk of hematoma.
You risk an epidural hematoma, which can cause paraplegia. It's a devastating complication. You must follow the ASRA guidelines strictly regarding the timing of stopping heparin or warfarin before you even think about doing a block.
Section 24, emergency surgery in VHD. A patient comes in after a car crash or with a strangulated hernia.
The priorities shift completely. You don't have time to bridge. If they are on warfarin, you reverse it immediately.
Oh.
FFP, vitamin K, or prothrombin complex concentrate, PCC, is the fastest way. If they have severe AS and are hypotensive from trauma, you start a phenylephrine infusion immediately. You put in an arterial line. You proceed only because the alternative is death.
Section 25, common exam questions and Viva traps. What do examiners love to ask to trip students up?
Trap number 1. How do you manage a pregnant patient with MS?
And the trap isn't the pregnancy itself.
The trap is the post-delivery period. As soon as the baby is born, the uterus contracts and squeezes about 500 milliliters of blood in autotransfusion back into the circulation.
And in a patient with tight MS,
that sudden volume load can cause flash pulmonary edema. You can be ready with diuretics right at the moment of delivery.
that's another one, trap 2.
Interpret the CDP waveform in tricuspid regurgitation. They want you to identify the giant CV wave.
Where the C and V waves merge.
Right. The regurgitation merges the C and V waves into one big systolic wave.
And a classic student mistake to avoid.
Treating AS hypotension with ephedrine. Ephedrine causes tachycardia.
Yeah.
And AS tachycardia is bad. You should say I would use phenylephrine.
And another one.
Forgetting PBMV. If they show you a chest x-ray of a young woman with a straight left heart border, that mitralization, you must always mention PBMV as a treatment option. Don't just jump to surgery.
Section 26, diagrams and exam presentation. We mentioned the loops.
Yes, you have to practice drawing them. 1, the normal PV loop. 2, the AS loop, which is tall, narrow, and shifted left because of the hypertrophy.
3, the MR loop.
Short, wide, and it loses its isovolumetric phases. And 4, the MS loop, which is just small because the LV is underfilled. If you can draw these correctly, you save yourself 10 minutes of talking and look like a star.
And how should you structure that 20-mark written answer?
Simple headings. Definition, etiology, pathophysiology, diagnosis, management. Split that into medical and surgical, and then anesthetic goals. Use that structure every time.
Okay, section 27, summary and exam conclusion. Let's wrap this up with the high-yield takeaways. Give us the bullet points.
Number 1, know the hemodynamics. NSAS equals slow, sinus tight. MRAR equals fast, full, forward.
Got it.
Number 2, know the etiology. Rheumatic is still number 1 for exams in India. Don't forget that. 3, know the interventions. TBI and PBMV are essential, modern knowledge.
And the prosthetics.
Number 4, know the anticoagulation. The bridging protocol for mechanical valves is non-negotiable. And finally, number 5, just remember you're managing the pump, understand the flow, and you pass the exam.
You are managing the pump. I like that. It's not just about knocking them out and waking them up. It's about keeping the flow moving second by second.
Exactly.
So a final thought for the listener to take away.
Go draw those PV loops right now. Don't just think about them. Put pen to paper and draw them. And consider this. The future is sutureless. The role of the anesthesiologist is evolving into that of an interventional echography specialist.
The eyes of the team.
You are the eyes of the surgeon during a TAVI or a Mitral clip. Master the echo, and you master the case.
Powerful advice. Good luck with the studies, everyone. You've got this. Thanks for listening to this deep dive.
Good luck.
See you next time.